Hi, welcome to the health segment of Western Wisconsin Journal. I'm Dr. Stephen Adorn. I'm a family practice physician in Hudson, Wisconsin, and today we're going to talk about midwives. And to help us is our special guest, Stephanie Johnson. Welcome to the show.
Thank you.
She is a midwife, and first of all, tell us, Stephanie, what does a midwife do? There may be a lot of people out there that don't even know what midwives do.
Sure. Nurse midwives like I am do a variety of different healthcare. We do mainly prenatal visits and catch babies, as we say. Moms deliver them, the midwife catches. And then postpartum care, but we also do well women exams, breast exams, pap smears, that kind of stuff. So
you've also been trained in gynecology too?
Right.
Okay. And are there just midwives that just deliver babies?
There are some midwives that just deliver babies. There are actually 3 different types of midwives in the United States. One type is a nurse midwife, which is what I am. The second type is called a certified professional midwife. And the third type is a direct entry or traditional midwife.
Okay. So what are the differences between the 3 types?
Sure.
Do they have limitations in what they can do? Or?
Sure. Certified nurse midwives typically in most states need to have a master's degree or a doctorate degree and also need to be a nurse along with the midwifery education. And so the certified professional midwives are trained, and I'm not as much of an expert in that area because that's not my training, but my understanding is they are trained through school and then also apprenticeship. They sit for a national exam just like the certified nurse midwives do. The third type, the direct entry or traditional midwives, do apprentice training only. So certified professional midwives and traditional midwives tend to practice outside of the hospital. I don't know of any that practice in the hospital setting. But certified nurse midwives, over 97% of them practice in a hospital.
Okay, so a lot of people think midwives do all the deliveries at home, but you really do all your deliveries in the hospital.
Yep. I've actually never attended a birth at a home before. I have a couple of friends who've I've been with when they've had home birth, but as a midwife, I've never attended a birth in a home. I only do hospital birth.
I see. Could you possibly do it at home if you so choose?
Well, there's
or is there some loopholes?
Yeah, there's some loopholes with malpractice insurance. They like you to choose your setting. A lot of the certified professional midwives and direct entry midwives don't carry malpractice insurance, and so they can practice outside of the hospital setting a little more easily. But vice versa, it's harder for them. They can't be credentialed in the hospital because they don't carry that malpractice insurance. So
and don't have all that specific training that you have in the nursing.
Right.
Yeah.
And my particular interest is to be in the hospital but provide a home-like experience there. I like to know that the equipment is behind the curtains and we can pull open the curtain and use the oxygen or the different kinds of equipment that we might need. It's there and available. But
so that raises an interesting point, at home versus hospital birth. And in the hospital, there's equipment and there's people around to resuscitate a baby, and then at home there may not be that type of thing. But I know a lot of people still deliver at home. Would you say you do a lot of deliveries? How many of those babies need some kind of resuscitation?
That's a good question. Of the low-risk women that I attend, I would say 2% maybe.
Okay.
It's very low.
It's very low. Okay.
But again, I'm dealing with mostly low-risk women and low-risk birth. But home birth women should be low risk also. So
you're trained in the neonatal resuscitation too, just like the rest of us?
Right.
Okay. Now, do you need to have obstetrical or OBGYN doctor back you up? Is that part of this?
Well, in the midwifery field, we like to call it a collaborative physician, not a backup physician. But yes, we do have a physician that's always available to us. They're not always in the hospital with us, but they're certainly readily available when we call if we need assistance or consultation, we need to transfer patient care, they're definitely available.
Right. I suppose with about 1 out of 5 people go into C-section, you're going to need that. Would you see, what's your like C-section, percentage, do you think? Do you think that you deliver more people vaginally than, let's say, the average doctor? Where are you at on that?
Yeah, statistics nationally, I would tell you that midwives' C-section rate tends to be below 10%, usually around 7%.
Wow.
And I would say mine is probably around that same. I haven't done any statistics in the year that I've been with Hudson Physicians, but
Sure.
I'd say it's probably around that same percentage.
Well, we know nationally it's up around 20%, and it's been going higher.
Yeah, it's actually closer to 30% now.
Yeah.
Climbing.
When I did deliveries, it was like 20.
Yeah.
But it seemed like 50% of mine were always going to C-section. That would always happen.
Yeah.
But that's really interesting is that in the, I'll call it traditional medical doctor field, that the C-section rate is going up, and it sounds like yours is really low nationally. What's the difference, do you think?
Well, I think, and what studies have shown is the difference is the time we spend with women. There's a lot of extra time really spent prenatally in education and kind of gaining confidence in each other. Both the patient gaining confidence in me and my skills, and me gaining confidence in them that they are taking good care of themselves and are motivated to have a healthy birth process. And so then also the time that we spend at the bedside. That's one of the hallmarks of midwifery, really, is that time that we spend labor sitting or labor, sitting at the bedside with women.
So you're there most of the labor then?
Right, right. Our commitment is to be with women in active labor. So meaning usually 4 or 5 centimeters on, we're at the bedside providing that support for both the mom and the father-to-be. So kind of helping them get through it.
So that's a lot of like psychological support and trust and all that kind of stuff, and I think that's nice, and maybe that helps prevent C-sections. But do you have any tricks that you do?
Well, sure. The nurses at the hospital would probably tell you, so I have some tricks that I've definitely tried to pass along. We do a lot of positioning, so in a lot of ambulation. I rarely have women who are laying in bed for a very long period of time. Okay. So I think that's really important in helping the baby be an active participant in the birth process.
And using gravity?
Yep, using gravity. Certainly use a lot of different techniques to stimulate contractions, like ambulation, sometimes using a breast pump or having the couple be together kind of thing.
Yeah.
I think that works well. And so there's some of the tricks. I'd use a lot of aromatherapy, massage, acupressure, water. I like to get people in the water for labor.
So you're right there all the time. You're watching it. You're watching the baby, and that's going to be really reassuring to the mom and the family there. That's, I remember. Okay, well, we got to get this baby to turn somehow, and we have the mom in all kinds of crazy positions. I suppose you do that too.
Yeah, sure we do.
It's like get on your hands and and see if we can get this baby to turn there.
Yeah.
Okay, all right. And then postpartum, what do you do?
Okay. So postpartum, each day that they're in the hospital, we see them. Do a lot of breastfeeding support, and so really encourage women to do the breastfeeding process, and then follow up with them in the clinic if they have issues with the breastfeeding, and then see women back at 6 weeks, talk about contraception issues, and that's really about it.
Well, it's kind of nice that you deal with the breast stuff, because a lot of times the doctors will say, well, we'll go have the lactation expert come and see you, but you are a lactation expert, I take it. So.
Well, in a way, yeah. I don't have the credentials behind my name, but yes, we do get quite a bit of training on it in school.
Like that. Okay. What is your philosophy, or maybe it's the midwife philosophy, it's kind of hard to separate those. What do you think about episiotomies? Why don't you tell everybody what episiotomies are, and what do you do with them? What do you do?
Sure. An episiotomy is a cut in the perineum, so between the vaginal opening and the rectum. And so a lot of times that was used to facilitate birth in And the thought process, I guess, historically was that it is easier on the tissue to have it cut versus tear. But really the research now is telling us that a tear will heal more easily.
Okay.
And a lot of women actually don't tear if you just let the perineum stretch on its own. And so my philosophy is I've really only cut 4 episiotomies in the years that I've been doing this.
Wow.
And those are really just for reasons like the baby's in trouble. Or something like that. But it's a rare occurrence that you really need to do that. If you just, a tincture of time and wait for the process to unfold, it works pretty well on its own.
So if there is a tear, do you repair it with suturing? Mm-hmm. You will do that?
Yep.
Okay.
Yep, I do that. Unless it's a significant tear, then I would call in my collaborating physician to
Oh, we all know
that.
about those.
Yeah.
We don't want those big tears to happen.
No, we don't.
There. Okay. Yeah, I remember it was almost like standard practice,
Mm-hmm.
cut an episiotomy.
Mm-hmm.
And then what my training at St. John's, we wouldn't deliver the midwife's babies because you see how the relationship, you don't throw a resident in there.
Yeah.
But they'd let me come in and watch, and that's where I learned how to do the delivery, how to control the delivery, how to talk to the mom, and all that kind of stuff there. And it's amazing, if you can control that delivery, you're going to get a good result on the mom's bottom. You're not going to get as bad tears. And boy, it sure saves a lot of time if you don't have to throw stitches in there.
That's exactly right. That's exactly right. And I think a lot of discomfort for mom too. We can save a lot of discomfort, so it's a good thing. I do also have women, of course, good nutrition helps that tissue, so we talk about that prenatally. Then I have them prepare that tissue with some oils at the end of pregnancy to help
stretch
stretch all that tissue out. So try to do some stuff before they go into labor, but then also, like you said, protecting the perineum and really helping that process unfold slowly. Yeah, it's kind of a technique.
How about philosophies on medication, like medications for pain?
That's a good question. Yeah, a lot of people think midwives don't believe in pain medication, and really you have to have a natural birth if you're having a midwife. Of course, we are skilled in helping women have a natural birth, and if that's what their desire is, we'll certainly help with that. But I'm not opposed to modern medicine, as I call it. We live in a time when epidurals are relatively safe, and I think a lot of women want to choose that option.
Oh, an epidural is what?
An epidural is a catheter in the back that gives a numbing sensation from about the belly button down to the toes. And so a lot of women will choose to do that to help alleviate the pain of labor. My encouragement is to really let their bodies get into good labor before they get that. Just like we were talking about earlier, having the baby get into the pelvis in a be able to be up and walking to make that happen. Okay. If you get an epidural, you can't get up and move.
Can't do that.
And so then I think that's kind of a detriment.
Yeah.
But if we get women far enough into labor, it tends to have less of an effect like that.
Okay.
So, and then I can also order IV narcotics. It's basically the same smorgasbord of pain medicine that physicians can order.
Use like Nubane, is that they still use that a lot? Because I've been out of delivery for about 4 years.
Yeah.
So
Same
okay,
thing.
so you get the Nubane, you do the. I think they do well. When we were more of our quote rural hospital, we didn't do too many epidurals, and so we did rely on the IV narcotics there in terms of that. So that's pain philosophy. What other philosophies that you have, like maybe like prenatal stuff? Do you talk about nutrition? Do you talk about like exercise, weight, stuff like that?
Well, I focus a lot on education with nutrition and supplements, working with your body to prepare. I say you're preparing for a marathon, really, and you have 9 months to do it. So the best time to start is right when you find out you're pregnant, or even before you're pregnant. So I encourage supplementation with folic acid, DHA, or one of the omega-3s. And then nutritionally, really work on, of course, the food groups, but really focusing on protein. So you're growing a healthy baby that way. And a lot of women have, the morning sickness or the nausea, and I think the protein in small amounts throughout the day really helps with that. So we'll talk through that. And then, yes, I really strongly encourage exercise. Okay. I think there's some great prenatal yoga classes and DVDs that I really encourage women to do, and then just walking. If women can get out and move, makes a big difference for labor. I always say labor is going to be shorter if you exercise, which it truly will be. So that's motivation usually.
No, I think the people, you know, that have been physically fit, the women, they recover quicker afterwards. And not that there's less pain during the labor, but they're kind of stronger. You know, have more endurance, and they're not going to poop out as much when it comes to pushing.
Yes, absolutely. That's very true.
It was interesting, at the local YMCA, there's the gal on the treadmill. I don't know, she looked about eight months along, and I'm like, when's she gonna stop running? But you know, she's always run, and she's run through the whole pregnancy, and she's motoring along there. But I haven't seen her lately, so I don't know if the baby's out or not. We'll find out in a few weeks, I guess.
Yeah. I really think that's a good deal to keep exercising for sure.
Yeah, okay. Well, anything we didn't hit on, like, I want to know the philosophy. I was kind of fascinated how you stay with the mom throughout the labor, that dedication. It's hard to have that dedication.
Well, it's hard for your lifestyle. You know, for a career and for an occupation, it can be really draining. I'm working currently now. I have a new partner, so that's really nice because then we can share a call. But otherwise, it can be really draining. And a lot of women who see me prenatally understand that my clinic schedule can kind of get shuffled around a bit, because if I've been up all night, I'm no good in the afternoon the next day in clinic. And so we'll oftentimes reschedule or that kind of thing. But people understand because they know when their time comes, they're going to have a midwife at the bedside.
So they're willing to sacrifice now for later when you're going to be there. So that seems like a major philosophical difference, because I know a lot of doctors is that just don't call me until the baby's just about to come out. You know, and you know, every once in a while they may pop their nose in, but they're not there the whole way. And I think that's nice for women.
Well, I really think it is the hallmark, like I said, of midwifery. I think that's the most important thing that we can provide, is that service of being with women. The word midwife actually means with woman. And so it's really what the intention of it is. And it's the part of the job that I love, is really to be in that birth energy and just help women in that intimate time really get through the process.
I'm pretty sure there were midwives before there were obstetricians.
Yes, very
going
much
way back.
Very much so. Basically the beginning of time, yes.
Like there's one for every village or something like that. All right, good. Well, very interesting. It's very interesting to see the philosophy difference. And you know, what type of people kind of come towards you, and what maybe go the other way towards an obstetrician?
Sure. Well, and I do a lot of, in my current place at Hudson Physicians, I do a lot of pregnancy confirmation visits, we call them. So I have a lot of women coming in who just found out they're pregnant and don't know if they're going to see an OB, a family practice, or a midwife. And so I just sort of do a rundown of all three. And I do think at Hudson Physicians, I'm biased, but I think we have really talented, you know, people in all areas. And so I always say I'm a little bit biased, free of course, because I think it's superior, but that's because I'm a midwife.
Exactly, yeah.
So I think that the people that are drawn, there are people who come and hear the whole story about what an OB and a family practice and a midwife are, and then choose it. But a lot of women are coming to a midwife because they've read about it, they have a friend that's had a midwife, they have...
Word of mouth, definitely.
Yes, it's definitely word of mouth, because people who have a midwife tend to be really satisfied. Not just me, but midwifery care in general, the patient satisfaction is higher.
Different.
And that's because of that time again, I think. You know, it's that personal relationship that you develop. So, yeah, I think that it doesn't always the women who are the tree hugger women, or the granola moms, we call them. Not always is it those moms. Sometimes, you know.
That's what I picture. I picture all these green people from River Falls want to have babies at home.
Sure. I have some women who are very interested in a home birth but can't afford it. I have women who say, you know what, I want an epidural, and I know I want an epidural in the parking lot if I can get it that soon. And so it's a really wide range, and really my philosophy is to meet them where they are. You know, again, hopefully taking that fear out of the labor and birth process, so the epidural can be postponed from the parking lot to maybe at least into active labor. But really a wide variety of women that I see and families from all walks of life.
So it's interesting. I think people that want somebody that they will have around a lot, that they have a long connection with prenatally, they know you're going to be there, and there's a trust. Then you have the obstetrician who can take you through into a C-section if you need to. So that's the one advantage there. And then you have the family physician who is going to not only take care of mom, but the baby too.
Absolutely.
So you kind of have your choices.
Yeah, yeah. Well, and I think that's the most important thing, is that women have those options available, and then they can choose. And not everyone's going to choose a midwife, just like not everyone chooses family practice or an OB. But I think that having that option available is a great thing, and it's becoming more and more available in the United States, and specifically the Midwest. It's finally starting to really take off here. So, yeah, and there's a rise in home birth, and I think that the reason for that is women are really seeking that one-on-one connection with their care provider when they're pregnant.
Right.
And then I continue, to see women for their annual exams, so I can develop that. A lot of times I'll have a relationship with someone and be doing their annual exams for a few years before they get pregnant,
Right.
and then do a preconception, then prenatal, and move on.
So you're doing their birth control, and you can advise them, okay, this is what you do with the birth control, and this is, okay, you get on the folate, and you get on all this. So you do that even before they're pregnant.
Yeah, that's ideal. That's the ideal relationship between a midwife and a patient. And then continuing that care all the way into menopause.
Right.
All the way through menopause.
Yeah,
So.
the fun time.
Yeah, right. The journey I'm on. Yeah, I do a lot of menopause care also. So I do a lot of bioidentical hormones and work with that kind of stuff too.
So really, you're a nurse practitioner.
A bit, yes.
That does gynecology, just all total women's care, from like gynecology to before they get pregnant, and birth control and all that kinds of, when they get pregnant, when they deliver, postpartum, and then as they get older. So it's women's care all through the life.
Spectrum. Yeah, I see young women, when they're just starting to get their period, and are trying to figure that part out, all the way through women who are struggling with hormone issues and menopausal symptoms. So yeah, all the way through that spectrum. I think it's one of the things people get frustrated with. Sometimes they'll come in for their annual exam, and I'm not a family medicine provider, and so they'll say, well, I have this mole on my back, can you look at that too? And I'll say, well, it looks okay, but you should probably see Dr. Adorn down the hall.
Go see Dr. Adorn, yeah.
Because I'm not a skin expert.
About a third of my practice has become dermatology, just out of necessity.
Yeah.
All right. Well, good. Thanks for being on the show.
Thank you.
I think this has been great for the audience. I think they get a better understanding of what a midwife does. I think I get a better understanding too, so I can utilize you or whatever. And thanks so much, Stephanie Johnson.
Thank you very much for having me.
And thank you for watching Western Wisconsin Journal. I'm Dr. Steve Adorn. Bye now.